everyone, this is Tricia Melhart, your state representative for the Oncology DPG. I would like to welcome everyone to our first Texas Oncology DPG webinar. I'm going to introduce our speaker in just a moment, but first I wanted to explain how the webinar is going to work. Karen will be speaking for approximately 45 minutes, and then we will start the question portion of our program. You can type your questions in the chat section of the webinar, and I will read them to Karen so that we can hopefully finish on time and end at approximately 5:30. I want to say a big thank you to Karen, the AICR, and the Oncology DPG for making this webinar possible. I hope you all find it very informative and that we can do this again in the future. All right, our speaker today is Karen Collins. Karen serves as the nutrition advisor to the American Institute for Cancer Research. She is a syndicated nutrition news columnist and is also the author of a new series of research papers for health professionals called AICR In-Depth that you can access from the AICR website. Based in Western New York, Karen conducted a long-time private practice in nutrition counseling that dealt extensively with weight and eating disorder issues, as well as a wide range of medical problems. Karen is a registered dietitian holding a bachelor's degree in dietetics from Purdue University and a master's in nutrition from Cornell. So without further ado, Karen, I'll turn it over to you.
Thank you. With all of the different things that we hear and that our patients hear about how nutrition and physical activity may reduce cancer risk, one thing that's hard to do is to find and help our patients find focus. It seems like an enormous puzzle with too many pieces sometimes. Today we'll look at key recommendations to lower cancer risk and how to identify which are the priorities that we should address in our work with individual patients and in the educational programs we provide. Surveys show that people vary widely in their perceptions about reducing cancer risk. Some people are somewhat skeptical, others believe reducing risk is possible, but essentially want to know what is the least amount of change they can make and still reduce their risk. Still others are eager to do everything they possibly can to reduce cancer risk and may need help identifying steps that are not worth the effort. The bottom line is that we need to answer three basic questions. Does diet matter? If so, what kind of diet? And importantly, can I follow that diet? I assume that most of you are somewhat familiar with the expert report from the American Institute for Cancer Research, Food, Nutrition, Physical Activity, and the Prevention of Cancer, a Global Perspective. The work of a panel of internationally renowned researchers, it summarizes reviews and meta-analyses of research and provides recommendations based on that work. Whenever you have questions or need documentation about recommendations, you can go to this website that's listed here where you can download any chapters of the report free of charge, and it's also where you'll find reports of the continuous updates. An important concept underlying the report's recommendations, and that we need to remember as we consider additional research published since, is that all studies are not equal, and conclusions of some can be weighted more heavily in identifying diet and lifestyle priorities than others. Report recommendations are all based on evidence rated convincing or probable, and you'll see on your handout the criteria the expert panel applied to identify this evidence. I know that many of you are primarily addressing questions of cancer survivors, so I thought we'd begin our look at the recommendations for reducing cancer risk today with this, a special recommendation from the AICR report that's directed to survivors. It says cancer survivors, we have to remember, include people that are still in active cancer treatment, those in the immediate post-treatment recovery period, and those looking at longer-term survival issues. Optimal nutrition may be quite different at each of these stages. The report says that after treatment, unless contraindicated for individual patients, cancer survivors should follow the recommendations for cancer prevention. There's not yet enough evidence to create dietary recommendations specific to cancer survivors, but it looks as though more physical activity and avoiding excess body fat lead to better outcomes. Let's start our walk through the steps to reduce cancer risk by looking at weight and physical activity. The first recommendation is to be as lean as possible without becoming underweight. AICR's expert report finds a convincing link between excess body fat and colon, postmenopausal breast, endometrial, kidney, esophageal, and pancreatic cancers, and probably gallbladder cancer. Excess body fat can be associated with insulin resistance, resulting in elevated levels of insulin. Insulin promotes proliferation in both normal and cancer cells, and many cancer cells reportedly have increased concentrations of insulin receptors, so that cancer cells may be especially responsive to growth signals from elevated insulin. Furthermore, increased insulin levels decrease liver synthesis of insulin-like growth factor binding proteins, which leads to an increase in bioavailable insulin-like growth factor 1. Like insulin, IGF-1 can promote cell proliferation and inhibits apoptosis in many tissues. In postmenopausal women, body fat becomes the primary site of estrogen synthesis. Coupled with the decreased levels of sex hormone binding globulin that result from elevated insulin, obesity may lead to substantial increases in bioavailable estrogen. Elevated levels of leptin that may occur in obesity can increase cancer development indirectly by promoting hyperinsulinemia, increasing inflammation, and by inducing the aromatase enzymes that increase estrogen levels in postmenopausal women. And they may also increase risk directly, as shown by in vitro studies in which leptin promotes cell proliferation and angiogenesis to allow metastasis. Adiponectin is a hormone with anti-inflammatory effects, and obesity is linked with decreased levels of this hormone, unlike other adipose-derived hormones. Reduced adiponectin may promote cancer development by increasing insulin resistance, increasing inflammation, and increasing tumor necrosis factor alpha and NF-kappa beta, which seem to increase cell proliferation and angiogenesis. Finally, excess body fat is also linked with elevated levels of inflammatory cytokines, which can lead to a chronic subclinical inflammation in which high concentrations of free radicals can damage cell DNA and create mutations that begin the cancer process. Furthermore, inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha seem to promote cancer development and progression through several different pathways. So the personal recommendations are to establish a body weight through childhood and adolescence that projects toward the lower end of the normal BMI range at age 21, and then to maintain body weight in the normal range, avoiding weight and waist gain through adulthood. But we shouldn't look at weight or BMI alone. Some studies suggest that up to 25 to 50% of adults with normal BMI may have what's called normal weight obesity. This has, they have high body fat, insulin resistance, and elevated levels of inflammatory cytokines. Waist size is not a perfect tool to assess this, since it doesn't discriminate between the subcutaneous fat around the waist and the deep visceral fat that seems to be what really poses most risk. But it clearly adds more to the picture than just looking at weight or BMI. In meta-analysis from the AICR continuous update on colorectal cancer that will be released shortly, each 1-inch increase in waist circumference is linked with a 3 to 5% increase in risk of colon cancer. And some studies suggest this link may be a risk factor that is actually independent of BMI. So we should encourage people to look at their waist. But instead of using the 40 and 35-inch cutoffs that are often cited by the National Institutes of Health, which are actually associated with obesity, since cancer risk begins at much lower levels of body fat, the expert report recommends using the cutoffs from the World Health Organization, which call for waist to be no larger than 37 inches in men and no more than 31.5 inches in women. And third, we can ask people how stable their weight is. The average American gains 1 to 2 pounds a year, which doesn't sound like much, but that means that by age 50, the average woman has gained 30 to 60 pounds, and that's gain that's especially associated with increased risk of postmenopausal breast cancer. Well, okay, so what do we say to people who have already gained excess weight? We don't have a lot of data on this, but the limited data we have relates primarily to breast cancer. In the Iowa Women's Health Study, among women who had all gained weight from age 30 to menopause, when they compared to those who continued to gain more weight after menopause, the women who maintained their weight showed a slight 7% lower risk of developing breast cancer, and those with at least a 5% weight loss showed a significant 22% lower risk. Well, We said that many of you work with cancer survivors for at least part of your time, if not all the time. So what do we say to cancer survivors about weight? Those who are already obese at the time of a weight-related cancer diagnosis show increased cancer mortality and increased all-cause mortality. But between the difficulties in conducting the long-term kind of studies that we need and, unfortunately, the limited long-term weight loss success that's in much of the literature, we really have very little data about the impact of intentional weight loss by survivors. However, we do know, at least from research outside the cancer domain, that weight loss does change levels of the inflammatory cytokines and hormones that seem to be the reason weight is linked with cancer risk. When we look at published research, we need to differentiate between weight change that's undesired from planned and gradual weight loss. Weight loss that's unplanned and leads to poor nutritional status in cancer survivors is linked with treatment interruption and decreased survival. Impact of weight gain is not clear for all cancers, but it may pose risk. I know that many of you are looking at weight with breast cancer patients, and you may find this review that's listed here by Vance helpful. It notes, for one thing, that for many, the weight gain that may be a concern actually begins a year or more after adjuvant treatment is concluded. So some of these women may unfortunately fall off our radar screen a bit. Unhealthy weight gain, the kind that's often seen with loss of lean body mass in addition to fat mass gain, is especially common in breast and prostate cancer patients. In breast cancer patients, this does seem to be associated with both increased breast cancer and overall mortality. Looking at our total approach to reducing cancer risk, we need to emphasize that excess body fat and weight gain are signs of a lifestyle that's out of balance. Part of that balance includes physical activity, and the recommendation is that we get at least 30 minutes of walking or other moderate physical activity every day. Evidence is now stronger than ever, with regular physical activity convincingly linked to lower risk of colorectal cancer, probably to lower risk of endometrial and postmenopausal breast cancer, and perhaps to others as well. One big problem is that many people expect weight loss from physical activity, and if they don't see it, they may lose their motivation. Results for each individual vary, but without any changes in diet, weight loss tends to be small. Here we see results from a randomized control trial of 173 overweight, sedentary, postmenopausal women. And after 12 months, those in the intervention group, who averaged about 30 minutes 6 days a week, lost less than 3 pounds. Although note that in a control group during stretching, they had actually begun to gain weight. So while physical activity can be really important to avoid weight gain and to help maintain weight loss that's achieved, without any change in diet, it may have very limited impact on weight loss, at least in some people. But a vital message that we've got to get out is that physical activity does change more than weight. Exercise lowers insulin levels and insulin resistance and decreases markers of inflammation. Exercise trials are not completely consistent about the impact of physical activity on estrogen levels without at least some body fat loss, but physical activity may have a direct link to lower estrogen levels, and its impact on immune function may help as well. So the personal recommendations are to get at least 30 minutes of moderate activity every day, such as brisk walking, and if possible, to work up to at least 60 minutes of moderate or 30 minutes of vigorous activity daily. And furthermore, we're advised to limit the amount of sedentary time that we have, such as watching TV.